Imagine completing a textbook upper blepharoplasty. Like, the incisions are flawless, the fat resection is perfectly conservative.
Right, everything looks great on the table.
Exactly. But then, a few weeks later, the patient walks into your clinic looking unexpectedly stern, angry, and, well, artificially aged. And the kicker, the mistake had absolutely nothing to do with the eyelids themselves.
Yeah, you missed a muscle completely outside the surgical field.
It's wild! Welcome to today's deep dive. If you are a plastic surgery resident staring down the barrel of your boards like the FRCS, you know these exams demand absolute precision.
They really do.
Oh,
And it is one of the classic traps in periorbital surgery. We can get so intensely focused on the local tissue that we forget the broader dynamic anatomy of the upper face.
which is exactly what we're getting into today. We are looking at a stack of revision materials based on the keynotes in plastic surgery framework. Our mission here is to strip away the noise and focus entirely on the high-yield mechanisms, surgical algorithms, and clinical traps for blepharoplasty.
Right, because we aren't just reciting facts today. We are going to break down, why the anatomy behaves the way it actually does. Treating the symptom rather than the mechanical cause is where the disasters happen.
Exactly. And before we get into that anatomy, make sure you hit follow on the show so you get all our revision deep dives. If you learned something today that helps you prep, leave us a rating.
And for mastering that factual recall, head directly to medsynclimited.com. You can grab the FRCS Plastic Surgery Anki deck there.
Yeah, it features over 6,000 topic-specific questions to really hardwire these facts into your brain. Okay, let's get straight to the surgical reasoning. A safe outcome starts long before the marking pen even touches the skin.
Absolutely. The notes highlight three main aims of the preoperative assessment.
Right, so identifying existing periorbital problems is the obvious one. But the second aim focuses on coexisting medical conditions.
Yeah, conditions that actively increase surgical risk. The board examiners they're looking for you to identify diabetes, thyroid disease, heart disease, and clotting disorders.
Let me pause you right there. Because it's easy to just memorize a list of diseases, But mechanically, why are these the heavy hitters for blepharoplasty specifically?
Well, think about the confined space we are working in. Like a clotting disorder in a standard skin excision on the arm might mean, a bit of oozing.
Right, nothing crazy.
But in the orbit,
Mm-hmm.
a minor postoperative bleed can rapidly become a retrobulbar hematoma,
Oh, wow, yeah.
which is a catastrophic emergency. And then thyroid disease, on the other hand, can cause exophthalmos. That fundamentally alters the globe-to-lid relationship and throws off your entire surgical vector.
Yeah.
You aren't just checking boxes on a form here.
You are anticipating mechanical failures.
Exactly.
Which brings us to the third aim, right? Spotting features that predispose to post-op dry eye and visual changes. Let's actually look at a specific trap from the notes.
Okay.
A patient comes in, they want periorbital cosmetic surgery, but they mention they recently had keratomylosis, better known as LASIK. What is the hard rule here?
Oh, the absolute rule is that periorbital cosmetic surgery must be avoided within 6 months of refractive surgery.
Wait, 6 months? Why 6 months? Like, what is happening at the tissue level that forces us to wait half a year?
It basically comes down to corneal innervation and tear film dynamics. Refractive surgeries like LASIK, they temporarily sever corneal nerves.
Okay.
And that dramatically alters reflex tear production. So now add a blepharoplasty to that equation.
Right, because blepharoplasty inherently alters blink dynamics and lid closure in that early post-op phase.
Exactly. If you compound a recovering denervated cornea from the LASIK with the altered lid mechanics and exposure from a recent bleph, you are severely compromising the eye.
You are basically stacking two completely different mechanisms of dry eye on top of each other.
You're creating a perfect storm for severe corneal complications. That's why your ophthalmological history must actively screen for things like glaucoma, existing dry eyes, excessive tearing.
Previous ocular trauma, contact lens use, all of that.
Yeah, all of it. All of these dictate the post-operative risk profile.
Okay, so you've cleared the history. Let's move to the physical examination. Because the notes emphasize specific pitfalls regarding the interplay between the brow and the eyelid. This brings us right back to that angry-looking patient from the opening hook.
Right. The concept here is compensated blepharoptosis. This is just a fascinating biomechanical interplay.
Walk us through it.
So in patients with blepharoptosis, there is an excess burden of skin resting on the upper eyelid. The body's subconscious response to this extra weight is to continuously fire the frontalis muscle to elevate the brow.
Oh, so they are actively lifting the tissue just to clear their visual axis and like lighten the physical load on the lid.
Exactly.
I always like to think of it as someone manually holding up a heavy, sagging curtain just to keep the window clear, you know?
Yeah.
The patient comes in complaining about heavy eyelids, but the root cause is actually higher up.
Yes. And here is the clinical trap that exams love. If you fail to recognize that the frontalis is doing all this heavy lifting and you simply perform a standard upper blepharoplasty, you remove that excess skin burden.
Right, so the eyelid can now open easily, the curtain is lighter.
The curtain is much lighter, so the brain senses that the compensatory elevation is no longer needed, and the frontalis muscle finally relaxes.
Oh, wow.
And when that happens, the eyebrow descends dramatically.
Leaving the patient with a hooded, stern, or aged appearance. I mean, you fixed the eyelid, but ruined the upper third of the face in the process.
Yeah, it's a disaster.
So how do you definitively prove this is happening during the physical exam, like before you cut?
You just ask the patient to close their eyes.
Really? Just close their eyes.
Yeah, because when the eyes close, the visual axis is no longer obscured. So the frontalis relaxes, and the compensated brow ptosis is immediately revealed by the descent of the eyebrows, right there in the chair.
Okay, so if you see that happen, what's the move?
You must manually hold the brow in the correct anatomical position for the rest of the examination. You hold it there to accurately estimate the true amount of excess eyelid skin by gently pinching it. These patients, they need a brow lift either before or concurrently with the blepharoplasty.
That is a massive distinction. The frontalis is essentially masking the true anatomy. Okay, let's shift our focus lower down, looking at the midface and the globe position relative to the orbital rim. The notes detail vectors. This sounds like physics, but how does it actually apply clinically? Let's start with the negative vector.
So vectors are assessed by looking at the patient's profile from the side. A negative vector relationship means the anterior cornea projects anterior to the infraorbital rim.
Okay, so think of a prominent eye with poor underlying bony support from the orbital rim.
Exactly.
The eye is essentially hanging out further than the bone beneath it. Why does that alter the surgical plan?
Because gravity and scar contracture are inevitably going to pull the lower lid down. In a negative vector patient, you lack that bony shelf to support the lid. Therefore, you must overcorrect the lateral canthal positioning.
Meaning you have to place it superior to its normal expected location.
Yes. If you don't overcorrect, that poor support will absolutely lead to lower lid malposition and corneal exposure.
It's like trying to string a hammock between two trees, but one tree is leaning away from you. You have to tie it higher to keep it from sagging.
That's a perfect analogy, yeah.
So what about the positive vector?
A positive vector relationship is the exact opposite. The anterior cornea is posterior to the infraorbital rim. These are patients with deep-set eyes.
Okay.
For them, you require posterior placement of lateral canthus to avoid anterior lower lid malposition. The bone provides plenty of support here, so your vector of pull changes completely.
Right, so the pre-op exam dictates the vector, which entirely dictates the technique.
Yeah.
But let's talk about what happens when things go wrong, despite perfect planning. Because board exams love testing the management of surgical nightmare.
They really do.
Let's look at the absolute worst-case scenario. It is immediate post-op. The patient is experiencing severe pain and their vision is threatened. The notes flag this as a 1 in 2,500 complication.
You are describing a retrobulbar hematoma.
Right.
And this is a rare but absolute surgical emergency. I mean, you have minutes to act.
Walk us through the pathophysiology. Like, why does a bleed here cause permanent blindness, whereas a bleed in the cheek just causes a bad bruise?
It is essentially a compartment syndrome of the orbit. Bleeding typically occurs from a postseptal artery. And remember, the orbit is a confined, rigid, bony cone.
Right, it doesn't stretch.
Exactly.
Yeah.
As this hematoma expands, it has nowhere to go. So it rapidly compresses the neurovascular structures of the eye. The mounting pressure cuts off the vascular supply to the optic nerve.
Wow.
And without perfusion, the optic nerve suffers irreversible damage, leading to permanent blindness.
So the clock is literally ticking. What are the immediate step-by-step actions?
Well, first, you do not wait for imaging.
No CT scan.
No, a CT scan will just confirm what you already know while the optic nerve dies in the scanner. It requires immediate bedside decompression. You open the surgical wounds and evacuate the hematoma right there to physically release the pressure.
Okay, and medically. The notes specify intravenous mannitol and acetazolamide. Why those two specifically?
Because they work synergistically to decrease intraocular pressure. Mannitol is an osmotic diuretic, so it draws fluid out of the eye.
And the acetazolamide.
Acetazolamide decreases the actual production of aqueous humor.
Mhm.
So while you decompress the orbit surgically, these medications decompress the globe medically. And concurrently, of course, you must seek an urgent ophthalmology consult. This requires a multidisciplinary emergency response.
Okay, let's step down from permanent blindness to other visual changes. Say a patient wakes up with double vision.
So diplopia is usually temporary. It's often attributable to simple local edema or a minor, non-threatening hematoma that's just affecting muscle movement.
But what if it isn't temporary?
If there is permanent strabismus, it means the extraocular muscles or motor nerves have been iatrogenically damaged during the dissection.
Okay.
And the notes specifically highlight that the inferior and superior oblique muscles are the most commonly injured in these procedures due to their proximity to the fat pads.
That makes sense. Now, we discussed dry eye earlier regarding the LASIK trap. As an early complication, how does it present and how aggressive should the management be?
It typically presents with itching, grittiness, burning, mucoid secretions, frequent blinking, and conjunctival injection. Because you assess the risk preoperatively, you can treat it preemptively.
Right.
Management includes ocular protection patches, temporary tarsorrhaphy or frost sutures to physically close the eye, aggressive corneal lubrication, and controlling the swelling with cold compresses and head elevation.
Another major early complication noted here is lower lid malposition. Why is the lower lid so much more temperamental than the upper lid?
It really comes down to gravity and structural support. Malposition is multifactorial, right? It can be caused by excessive removal of skin, muscle, or fat.
Okay.
It can result from the downward pull of scar contracture, an intramuscular hematoma, paralysis of the orbicularis oculi muscle, adhesions of the orbital septum, unrecognized proptosis.
Or just failing to correct lower lid laxity in the first place. But
Exactly. The lower lid is simply less forgiving, period.
and looking long-term, what late complications are examiners looking for?
One major one is logophthalmos. That's the inability to close the eyelids entirely.
Right.
This often resolves as postoperative edema subsides, managed initially with just massage, taping, and lubrication. But if it persists long-term, it implies excessive skin resection. Those patients may require scar release and full-thickness skin grafts.
The other late complication mentioned is the hollowed-out look.
Yes, caused by excessive postseptal fat resection. It leaves the patient with this undesirable skeletal appearance. And to treat it, you actually have to replace volume using fat transfer or injectable fillers to mask the prominent orbital rim.
So to prevent these complications, the hollowed-out look, the logophthalmo surgical technique and precise markings are paramount. And exams absolutely require you to know the exact numerical measurements.
They do.
So let's go through the markings for an upper blepharoplasty.
Okay, for an upper bleph, the lower border of the excision is marked in the supratarsal crease. Anatomically, this is approximately 10 millimeters superior to the ciliary margin.
10 millimeters. What happens mechanically if a surgeon gets aggressive and dips below that?
Well, if you place the incision too close to the lid margin, you risk damaging the delicate pretarsal tissues. You can actually destroy the natural fold of the eyelid. You must maintain that 10 millimeter distance.
Okay, and what about the medial and lateral boundaries?
Laterally, you continue in a natural skin crease, but you absolutely must not extend beyond the lateral orbital rim.
And medially?
Medially, the strict boundary is the caruncle. If you cross that medial boundary, you run a high risk of creating severe visible scar webbing.
Right. Now, for the upper border of the skin excision, you pinch the skin with forceps to estimate the redundancy. But there's another strict measurement here relative to the eyebrow.
Yes, the critical rule is that the superior marking must remain greater than 10 millimeters below the inferior border of the brow. This preserves the brow lid aesthetic unit.
Okay, now let's talk about the fat pads. When accessing the medial and central fat pads to address upper lid fullness, you make small incisions in the orbital septum. The notes are very specific here. The orbital septum must be opened superiorly.
Right?
Why are we so dogmatic about staying superior? Because, some older literature suggests a direct central approach to the fat pads is faster.
It is entirely about the levator aponeurosis.
Yeah.
That's the lifting mechanism of the upper lid.
Okay.
The levator aponeurosis merges with the orbital septum inferiorly. So if you try to open the septum low or centrally, you are highly likely to iatrogenically injure the levator.
Which leaves the patient with a postoperative ptosis.
Exactly. A droopy eyelid that will require secondary surgical repair. You must stay high, open the septum superiorly to protect the levator aponeurosis.
Got it. Let's move down to the lower blepharoplasty. The text notes the technique of choice here is controversial, and outcomes are notoriously less predictable than the upper lid.
Very true.
So break down the transcutaneous approach versus the transconjunctival approach.
Sure. The transcutaneous approach uses a single subciliary incision, limited immediately by the lacrimal punctum, and continued inferolaterally into a skin crease for about 5 millimeters.
Okay.
A crucial technical point here. You must preserve a 10 millimeter vertical skin bridge between the upper and lower lid incisions to avoid lateral scar webbing.
Right. And once you incise the skin, you have a choice of dissecting planes. This is where a lot of debate happens on the boards. Differentiate the skin flap method from the skin muscle flap method.
Okay, so in the skin flap method, the skin is separated from the underlying orbicularis muscle down to the infraorbital rim. You then incise the junction between the pretarsal and preceptal orbicularis in the line of the muscle fibers.
To access the septum and the orbital fat.
Right. The skin flap is then regraped, and the redundant skin is excised.
And the skin muscle flap method, how does the dissection change there?
Here, the skin is separated from the underlying pretarsal orbicularis, but the preceptal orbicularis is elevated with the skin flap down to the inferior orbital rim. This exposes the septum for fat access while attempting to leave the pretarsal orbicularis intact.
Now, this sounds like it provides great exposure, but what is the physiological risk?
The major risk is denervation. Critics argue this approach damages or denervates the orbicularis muscle. Since the orbicularis acts as a sling supporting the lower lid, denervating it directly leads to postoperative lower lid malposition and ectropion.
But it's still a widely used technique, so what is the counterargument?
Proponents of the skin muscle flap argue that postoperative electromyographic evidence (EMG) studies shows that the pretarsal orbicularis muscle actually remains functioning.
Oh, interesting.
Yeah, it's an ongoing controversy between clinical observation of malposition rates versus objective electrophysiological data.
We'll come back to that. Briefly, what about the transconjunctival approach?
This approach enters from the inside of the lid, meaning it does not address skin excess at all. If they have excess skin, you need a separate excision or resurfacing.
Okay.
It has two options, preceptal or retroseptal. The preceptal option divides the capsulopalpebral fascia and septum, dissecting between the septum and orbicularis. The retroseptal option is slightly lower, going through the conjunctiva and capsulopalpebral fascia only, allowing you to enter the fat compartments directly without violating the septum at all.
Which brings us to a guaranteed exam topic. Because lower lid approaches carry such a high risk of malposition, mastering the algorithm for lateral canthal support based on lid laxity is essential.
Absolutely.
Let's break down the exact management of lower lid laxity based on the anterior traction test measurements. First, how are we measuring this?
The anterior traction test involves gently pulling the lower lid anteriorly away from the globe. You literally measure the distance the lid can be displaced.
And the management is strictly categorized into minor, moderate, and severe laxity. Let's start with minor laxity, defined here as 1 to 2 millimeters of anterior traction.
For 1 to 2 millimeters, the structural integrity is mostly intact. You have two main options here. First is a temporary tarsorrhaphy, which sutures the lids together to protect the cornea and prevent early cicatricial atropion while swelling subsides.
Okay, and the second?
Second is an orbicularis muscle sling.
How does the sling work mechanically?
The supralateral edge of the lower lid preceptal orbicularis is dissected free for about 1 centimeter. This muscle flap is transposed to the lateral orbital rim via the upper blepharoplasty wound and secured with sutures to the periosteum.
So it essentially tightens the muscular hammock supporting the lid.
Exactly.
What if the laxity is moderate, 3 to 6 millimeters of traction? Why isn't a muscle sling enough here?
Well, at 3 to 6 millimeters, the laxity is too profound for muscle alone to hold the tension. The muscle will simply stretch. You need a structural step up. Moderate laxity requires a lateral cantopexy,
Which involves the ligament itself.
Right. It tightens the lower lid by suturing the canthal ligament and the rigid tarsal plate directly to the lateral orbital rim periosteum.
Okay.
A common method is the transcanthal canthopexy, passing a double-armed permanent suture through a small incision in the lateral canthus to secure it firmly to the periosteum.
And finally, severe laxity. Greater than 6 millimeters of anterior traction. I mean, the lid is basically pulling entirely away from the eye at that point.
Yeah, severe laxity means the tendon is structurally compromised. Suturing it just isn't enough. You must perform a lateral canthoplasty.
What does that involve?
This involves the actual division and repositioning of the inferior limb of the lateral canthal tendon. If the patient has significant lower lid redundancy accompanying this severe laxity, you must perform a Kunt-Simanowski procedure.
Oh, that is a classic board name drop. What exactly is a Kunt-Simanowski procedure?
It combines a catholysis releasing the tendon with a full-thickness lid resection to physically shorten the redundant lid. You are literally cutting out the slack.
So by understanding the mechanical failures, whether it's tendon laxity, fluid compartment pressure, or compensatory muscle action, the surgical algorithms become logical extensions of the anatomy, rather than just blind lists to memorize.
Yeah, absolutely.
Or-
And, as you prepare for your exams, I want to leave you with a high-level concept to ponder.
Hmm.
Consider that ongoing controversy we discussed regarding the lower blepharoplasty skin muscle flap approach.
Right.
You have conflicting views. The clinical risk of orbicularis muscle denervation leading to lid malposition versus the electromyographic evidence proving preservation of function.
The clinical observation versus the objective data.
Exactly. So if an examiner pushes you on your choice of approach and the subsequent risk of post-operative lower lid malposition, how might you defend your decision? How do you weigh EMG data against physical outcomes in your own practice?
That is a fantastic question to mull over. The textbook might give you the algorithm, but your surgical reasoning must justify it. To everyone listening, if there's a specific anatomical nuance we covered today that you want clarified, leave a comment or a question below.
And remember, head over to medsynclimited.com to grab that FRCS Anki deck.
Yeah, with over 6,000 topic-specific questions, it is the most efficient way to drill these facts into your memory. Don't forget to rate the show and hit follow for more revision deep dives. See you on the next deep dive.